Welcome to the Clinical Masterclass, Transplantation and Immunosuppression. You know, post-transplant care is really the ultimate high-stakes balancing act. We are constantly trying to preserve a newly grafted organ while simultaneously managing the very real, everyday threat of drug toxicity and systemic infection. It's a tightrope walk, for sure.
Let's jump right into round one, immunology and immunosuppression.
Okay, let's dive into this. Question 11. Which of the following circulating cells in the blood carry out phagocytosis? We've got neutrophils, monocytes, macrophages, NK cells, and T and B cells. The correct answer is A, neutrophils. These polymorphonuclear leukocytes are absolutely your definitive first responders. They completely dominate that crucial initial 24-hour cellular infiltrate during early graft ischemia reperfusion injuries. They're the ones rapidly migrating to acute inflammation to recognize and destroy pathogens. Keep your exam pearls in mind here. Phagocytosis goes into absolute overdrive when pathogens are opsonized with complement components like C3b or IgG antibodies. And hey, don't confuse them with monocytes. Monocytes are just the circulating precursors. They only differentiate into macrophages once they actually leave the bloodstream and physically enter the tissue matrices.
Moving on to question 2. Which of the following drugs blocks the action of the enzyme calcineurin? Scan those options. We have cyclosporin, sirolimus, mycophenolate mofetil, azathioprine, or basiliximab. Go ahead and lock in your answer.
So the correct choice is A, cyclosporin. Let's actually trace this intracellular pathway step by step. Down in the cytoplasm, cyclosporin binds to its specific immunophilin receptor, which is called cyclophilin. This new complex directly inhibits the phosphatase activity of calcineurin. By doing that, it completely prevents the nuclear translocation of NFAT, and that ultimately blocks the transcription of the interleukin-2 gene. Now, why does that matter? Well, because IL-2 is the primary autocrine growth factor driving T-cell expansion. If you block IL-2, you literally halt cell-mediated graft rejection cascades dead in their tracks. Now, I want you to contrast this with tacrolimus. Tacrolimus also blocks calcineurin, but it binds to a totally different target called FKBP12. And whatever you do, do not mix this up with sirolimus. Sirolimus does bind FKBP12 as well, but it doesn't inhibit calcineurin at all. Actually, scratch that, it blocks the mTOR pathway instead.
Question 10. Which of the following are the mainstay for immunosuppression following a renal or solid organ transplant? The options include a few single agents, and then option E, cyclosporin and tacrolimus.
And this brilliantly illustrates the correct answer, which is E. Calcineurin inhibitors, specifically cyclosporin and tacrolimus, form the absolute baseline maintenance cornerstone. This is the modern standard of care right here, the triple therapy regimen. You pair a calcineurin inhibitor, usually tacrolimus because it has lower acute rejection rates, with an anti-metabolite like mycophenolate mofetil and low-dose corticosteroids. A massive pearl to remember for the exams is therapeutic drug monitoring, or TDM. You absolutely must use serial blood draws to keep these drugs in a super tight therapeutic window. It's a delicate balance between graft protection and severe nephrotoxicity. Also, pay attention to how the anti-metabolite mycophenolate mofetil actually works. It reversibly inhibits IMDPH, which basically blocks the de novo purine synthesis pathway that lymphocytes so desperately need to multiply.
Round 2. Timelines of graft rejection.
Let's look at question 7. A patient with a known history of renal disease develops graft failure exactly 3 months after their transplant. Based purely on this timeline, what type of rejection is this? Is it hyperacute, acute, subacute, or chronic?
The correct answer is B, acute rejection. The timeline is your ultimate diagnostic compass here. Think about it. Hyperacute rejection happens immediately. We're talking minutes to hours right there in the operating room, triggered by preformed circulating ABO or anti-HLA antibodies. Acute rejection, which is exactly what our patient has, manifests anywhere from days up to 6 months post-transplant. It presents with rising serum creatinine, oliguria, graft swelling, or low-grade fevers, and it can be cell-mediated or antibody-mediated. Finally, chronic rejection is much more insidious. It creeps in after 6 months to years, driven by fibroproliferative endarteritis and ischemic fibrosis.
Right into question 8. A 50-year-old man is 4 weeks post-cadaveric renal transplant. He develops fever, graft tenderness, and oliguria. His serum creatinine spikes to 3.1. A renal ultrasound shows mild edema, but crucially normal flow in both the renal artery and vein. A nuclear scan shows sluggish uptake. What is the most appropriate next step in his management?
So, The crucial point here is that the normal ultrasound just ruled out acute macrovascular thrombosis. At 4 weeks out, we are squarely in the acute rejection window. Therefore, the correct answer is D, performing a renal biopsy followed by a steroid boost and immunoglobulin therapy. A percutaneous core needle biopsy is the absolute gold standard in this scenario. You literally have to confirm the diagnosis to differentiate acute cellular rejection from calcineurin inhibitor toxicity. Now, acute cellular rejection histologically shows CD8 plus T cells invading tubular basement membranes, which we call tubulitis. Once you've confirmed that, you therapeutically escalate with high-dose intravenous methylprednisolone pulses. If it's resistant, you bring in the big guns, antithymocyte globulin, plasmapheresis, or IVIG.
Question 3. What is the main risk factor contributing to chronic rejection down the line? The options are inadequate immunosuppression, prolonged cold ischemia, CMV infection, poor HLA match, or previous acute rejection. The answer is E. While non-immune vectors like cold ischemia times over 24 hours, advanced donor age, and viral triggers like CMV definitely accelerate vascular changes, a history of previous acute rejection episodes is hands down the single most powerful clinical predictor for the subsequent development of chronic graft rejection.
Round 3, post-transplant clinical complications.
Question 1. 2 weeks following a renal transplantation, a patient develops pain in the lumbar region below the incision line, accompanied by weakness in their ipsilateral leg. What do we think is the possible cause here?
The correct answer is B, damage to the femoral nerve. This is a very well-recognized iatrogenic complication. It's caused by excessive mechanical retraction, often from a Balfour or Omni retractor, which ends up compressing the nerve right against the psoas major muscle. Femoral nerve compression gives you a combined motor and sensory deficit, so you'll see impaired knee extension, trouble climbing stairs, and sensory loss over the anteromedial thigh. Compare that to the lateral cutaneous nerve, which causes meralgia paresthetica. That is purely sensory paresthesias of the anterolateral thigh, but with totally normal motor strength. And then, of course, there's the genital femoral nerve, which is marked by an absent ipsilateral cremasteric reflex.
Question 4. A middle-aged patient with a pancreatic renal transplant later presents with a fractured neck of the femur. Which of their immunosuppressive drugs is the most likely cause?
The culprit is A, corticosteroids. Corticosteroids like prednisone are infamous for causing post-transplant metabolic bone disease and severe secondary osteoporosis. They basically downregulate osteoblast function while simultaneously stimulating osteoclast activity, literally leaching the bone. Steroids give you cushingoid changes, cataracts, and osteoporosis. Calcineurin inhibitors, on the other hand, are dominated by nephrotoxicity and neurotoxicity. To be even more specific about it, cyclosporin causes cosmetic side effects like hirsutism and gingival hyperplasia, whereas tacrolimus heavily correlates with alopecia and severe post-transplant hyperglycemia.
Let's move to question 6 and see how this builds. Which of the following is the most common infection in a post-transplant patient? We have Epstein-Barr virus, histoplasmosis, cytomegalovirus, or candidiasis.
The correct answer is C, cytomegalovirus, or CMV. This is simply the most common, clinically significant viral pathogen in solid organ recipients. It's usually lurking and typically manifests within that initial 1 to 6 month post-transplant window, which is exactly when systemic immunosuppression is at its absolute peak. You have to match the donor and recipient serostatus. If the donor is positive and the recipient is negative, that carries the highest risk, and you must routinely manage it with prophylactic valganciclovir. Also, definitely note the relationship with EBV mentioned in the pearls here. Chronic T-cell oversuppression can allow unchecked EBB-driven B-cell proliferation, which risks post-transplant lymphoproliferative disorder.
Round 4, Selection and Organ Procurement.
Here is question 5. A patient with known hepatocellular carcinoma is planned for treatment. Which child Pew class actually warrants liver transplantation as a treatment option? Class A, B, C, D, or E?
Now, what's really interesting about this is the answer is A, Child Pug Class A. According to the BCLC framework, a patient with early-stage malignancy but well-preserved liver architecture, that's Class A, who has elevated portal pressures, is actually the ideal candidate for curative transplant. We are using the Class A constraint to determine if a patient undergoes primary surgical resection versus a formal transplant. Just a quick reminder, the Child Turkid-Pugh score uses bilirubin, albumin, INR, ascites, and encephalopathy. But the MELD score, which is used to prioritize organ allocation on the waitlist based on mortality risk, relies strictly on objective labs. Those are serum creatinine, bilirubin, and INR.
And for our final vignette,
Question 9. What is the correct protocol regarding organ donation from a brainstem dead patient? Can the doctor on duty just decide? Does the hospital administration take over?
The correct answer is C. Consent must be taken from the relatives of the patient, even after formal brainstem death criteria are rigidly certified. And yes, that includes apnea challenge tests and excluding metabolic mimicry. The local organ procurement organization must secure clear formal consent from the next of kin. Furthermore, the clinical team treating the dying patient has to remain absolutely separate from the procurement team to eliminate any conflict of interest. Mastering these clinical protocols doesn't just make you a better test taker, it's what bridges medical science with human empathy. So how will you apply this delicate balance in your own clinical practice?